Hello, everyone, and thank you for attending my presentation, Maternal Mental Health, Understanding the Factors. My name is Dr. Janine Cross. I am Assistant Professor at Howard University School of Social Work, and I'm able to bring you this presentation as part of a larger grant that the Howard University School of Social Worker has with the Substance Abuse and Mental Health Administration Services Administration. I am co-principal investigator on a SAMHSA grant with our dean, Dr. Sandra Edmonds Crew. She's also dean as well as professor of Howard University School of Social Work. And welcome. This presentation will start off by talking about some of the challenges faced by pregnant mothers. Before we can have a robust understanding and discussion of maternal mental health, we need to be abreast of what are some of the major challenges that are being faced today by pregnant women and postpartum women, particularly minority women, African American women, as well as Latinx populations. We need to really understand that there are so many social factors that really impact someone's mental health. Mental health and challenges with mental health don't occur in vacuums. Oftentimes, there are things that are happening in our environments and around us that may cause us to have deteriorations to our mental health. We also know that there are biological and imbalances that happen within us that also causes us to have mental health challenges. And understanding that, we'll talk more about that as well. So we're going to really do a deep dive in some of the major issues facing pregnant women and postpartum women. And then we're going to then talk more in depth about some of those specific mental health challenges, or as we call them, perinatal mood disorders that tend to impact pregnant women, as they are oftentimes very much related to the factors that I'm going to discuss early on. And then we're going to end this presentation by finishing off by talking about some of the treatments that are available for pregnant and postpartum women, and some evidence based approaches that can help support this population. One of the major challenges that are facing pregnant women at this time, particularly women of color, is maternal mortality. Currently, in the United States, the mortality rate is 20.7 deaths per 100,000 pregnant women. In DC specifically, the mortality rate is 23.1 per 100,000. In DC specifically, 70% of deaths occurred in DC occurred with African American women. We also know that when we are looking at the DC mortality rate, some of the highest death rates occurred in areas that had the highest poverty and had the largest number of Blacks in the population. And in DC, that is Ward 7 and 8. We also know that Black mothers represent 50% of all births in DC specifically, yet comprises 90% of the pregnancy associated death. Those mortality rates were provided by the DC Maternal Mortality Review Committee annual report. So as you can see, maternal mortality is a growing issue nationally, but what we are seeing, particularly in the District of Columbia, maternal mortality has taken its toll on some of our most vulnerable populations. And we have seen that maternal mortality has also impacted the Black and Brown community the most severely. And there are plenty reasons for this. We can have a discussion related to racism, biases in healthcare systems, how Black women are treated historically, how Black women are viewed in terms of their bodies, and how rights are oftentimes removed from them. We can also talk about how access to healthcare and insurance plays a role in mortality outcomes for African American women, but it is an alarming rate, and we should be concerned about the deaths. Oftentimes, we see this only when it's related to celebrities. We've heard of countless celebrities who've said that they've had challenges with healthcare systems, particularly medical providers not listening to them when they had concerns about their healthcare. Um, we also know that there are a lot of changes in healthcare systems in which we're trying to be more attuned to understanding the needs of African American women, but we have a long way to go. Um, and at this time, we are at a high risk population, particularly African American women, as it relates to maternal mortality, and more needs to be done. There are maternal mortality review committees that are actually developing throughout the country. DC has its now new maternal mortality review committee working on its second annual report to disseminate the findings on why this is happening, and why certain communities, particularly African American women, are most affected. And also providing some recommendations on how to improve the outcomes for African American women, particularly in DC. And so we need to better understand what is going on so that we can improve the maternal mortality outcomes for our populations. Substance use is another growing concern in pregnant and postpartum women. A 2019 study of pregnant respondents disclosed that during pregnancy, there was not a lot of support. And specifically, 68% of respondents in a 2019 study said that they received counseling about the effects of prescription opioid impacts on their infant. In that same study, 21% of women admitted misusing prescription drugs. We also know that 27% of respondents in that study also said that they needed and wanted to cut down on their prescription use. In that study, it also identified African American and Latinx respondents as being overrepresented um, compared to their white counterparts as it relates to prescription use. And the rates here, 8.6% and 7% respectively, compared to 5.9% of white respondents. Substance use is also becoming an epidemic. We are concerned about the rates of substance use in prenatal and postpartum populations, substance use and overdose as well. There are trends showing that African American women and minority women overall are starting to increase substance use and having substance use related overdose and deaths. And so this is a tremendous problem in our population as well. We are trying to do more in terms of increasing awareness to substance use in populations, as well as doing better substance use screening with pregnant and postpartum women. Oftentimes, there are medical bias in terms of, and stereotypes in terms of what substance use looks like and in what populations it tends to be more prevalent. You often see, oftentimes, where African American women are oftentimes being seen as those populations that are misusing substance use. And oftentimes, child welfare services are also often involved in a punitive way rather than in a supportive way to help and support these mothers. We also know that there are biases in terms of how they are screened and who are screened. And to be more specific, African American women are oftentimes perceived and screened for substance use more so than white pregnant women. And this is a bias. We need to get away from biased practices in healthcare and either move toward more universal screening standards, and better education of medical providers so that we're doing a better job making sure that we are targeting populations that are at high risk in a respectful way, but not also using stereotypes about populations to treat them inappropriately, accuse them, and not listening to their needs and supporting them. Again, we do know that African American women are trending and an increased use of substance use, particularly related to opioids and prescriptions. But that means we need to do a better job of supporting them and screening them, but also doing a better job with not being biases in the way we screen and to make sure that we're not letting our prejudice, racism, and biases cloud the way we practice and need to implement more evidence-based standard of care procedures in our treatment and support of pregnant and postpartum women. Neonatal abstinence syndrome related to opioids and prescription drug use is another challenge in pregnant populations. The national opioid use disorder rates quadrupled at labor and delivery. And we also know that neonatal abstinence syndrome has increased in prevalence from 1.5 per 1,000 births to 8.0 per 1,000 births between 2014 and 2004, and 2014, respectively. So again, this is also becoming an alarming problem in this population. We also know that pregnant women are at risk of returning to substance use shortly after giving birth. And 83% of women achieve abstinence from at least one substance use during pregnancy, but oftentimes return to substance use at 3 months postpartum. Neonatal abstinence syndromes is the condition in which we identify infants that are withdrawing and exposed to substances, particularly opioids. And some of the symptoms that infants experience are listed here: sleep problems, sneezing, feeding difficulties, tremors, high pitched crying, seizures, temperature instability. Infants who are diagnosed with neonatal abstinence syndromes oftentimes can end up in the newborn intensive care nursery and spend several weeks and up to a few months withdrawing and getting care and treatment for neonatal abstinence syndrome. And this is a consequence of opioid substance use in pregnant and parenting populations. When substance use is a concern and a problem for pregnant and parenting women, we're also understanding that mental health and substance use are strong pathways to imprisonment and incarceration. Pregnant women in prison oftentimes do not receive the appropriate prenatal care um, due to substance use. We oftentimes apply a criminal approach to a public health issue such as substance use and perinatal substance use. And oftentimes pregnant women find themselves incarcerated. And we also know that African American women and Latinx women are overrepresented in the prison systems as well. When pregnant women are incarcerated, they are not getting the healthcare services that they need. We know that they are not appropriate places for pregnant and postpartum women. In prison, pregnant women oftentimes lack the appropriate nutrition, such as appropriate food and water. They do not have access to sanitary products or appropriate standard prenatal care, as well as postnatal care. They're not getting the important counseling services and support in prisons. They oftentimes get scant medical attention and often the product of that is prison births. Often we see in pregnant women in prison shackling. Prison shackling policies are very dangerous. Women are shackled in the prisons, and they're shackled when they are released from prison to attend medical appointments. They're also shackled at the time of labor and delivery. What we know is that these shackling policies are harmful and dangerous to pregnant women as well as their infants, unborn infants. They're dangerous because it limits their balance and mobility. It increases the risk of falling, which can also cause placental abruption, hemorrhage, and stillbirth. Shackling also increases the chances of blood clots and interferes with medical providers' ability to provide care, as well as standard and emergency care to pregnant women. Most states either allow shackling or have vague laws restricting the practice. Again, a byproduct oftentimes of substance use, but oftentimes, again, a poor response to not supporting pregnant and postpartum women. What we need to do is make sure that we understand that public health policy and supporting these mothers, getting them into support and treatment is what's needed, not these criminal responses that end them up in jail that are poorly equipped to meet the medical and support needs of pregnant and parenting women. Infant mortality is also a concern, particularly amongst African American women and minority women in general. What we know is non-Hispanic, Black, and African Americans have 2.3 times the infant mortality rate as non-Hispanic whites. We also know that non-Hispanic, Black, African American infants are 4 times more likely to die from complications related to low birth weight as compared to non-Hispanic white infants. We also know that non-Hispanic, Black, African American infants are twice as likely to suffer or die of sudden infant death syndrome. And we also know that non-Hispanic, Black, African American mothers are also twice as likely to receive late or no prenatal care as compared to non-Hispanic white mothers. And this also results in poor outcomes for African American infants. The infant mortality rate per 1,000 live births per race is listed here. You see it's 10.8 for African Americans, 4.6 for whites. Infant mortality is also a concern for pregnant and postpartum women. Infant mortality is particularly a concern for African Americans, as you can see that our rates are higher. And this is important to understand. So when you think about maternal mortality and its impacts on African American women and minority women overall, when you think about substance use, infant mortality, and the consequences, incarceration, and also when you think about mental health, which is also a pathway to imprisonment for women, particularly pregnant women as well, you get to understand how these social factors, issues, challenges that we are dealing with now can impact mental health and worsen the mental health of pregnant and parenting women. Depression. 1 in 8 women experience symptoms of depression. We know that when women have a history of depression, that puts them at higher risk for postpartum depression. We also know that there's not enough screening and assessments for depression that needs to happen for pregnant and parenting women. 1 in 5 pregnant women are not asked about depression or depression symptoms. And we also know that over 50% of pregnant women do not get treated for depression. We also know that depression diagnosis in delivery is increasing, at the time of delivery is increasing. And it is 7 times higher in 2015 than what it was in 2000. And so depression amongst pregnant and parenting women is a growing concern. We are trying to increase awareness of depression in pregnant populations, trying to increase the rate of screening. The goal is to make sure all pregnant and postpartum women are screened for depression. And not only that screening is occurring in real time at appropriate times throughout the pregnancy, but also making sure that the resources are there to support the women. Oftentimes, medical providers are not doing routine screening for depression and other perinatal mood concerns, but also they do not do the screenings because they're concerned about being ill equipped to deal with positive screening results, not having appropriate staff such as perinatal social workers on site to deal with it, psychologists on site to deal with it, not having enough resources in the community to deal with depression, whether that's inpatient or outpatient resources. And so we know that these routine depression screenings are not occurring. But we also know that these routine depression screenings are key to early detection and improving outcomes for pregnant and postpartum women. Anxiety. 1 in 5 women experience symptoms of anxiety, and it can occur anytime during the pregnancy and after. Some studies demonstrate that anxiety as well as depression can show itself postpartum up until 6 months, up until 1 year of life for that infant. And so that means that we need to make sure that we're constantly screening, not just prenatally and postpartum, but also checking in with our postpartum women, and understanding that they are at risk for suffering from depression up until their infant is 1 year old, 1 years of age. The reason why we want to make sure that we highlight this need to understand the concerns and risks for pregnant and parenting women is because it's biological and it's also psychosocial. We know that there are a lot of hormonal changes that occur during pregnancy and postpartum, and that rapid change in hormones when you become pregnant and that decrease in hormones after you deliver oftentimes will result to those mood instabilities that put pregnant women at risk. And so we need to be very vigilant of our pregnant and postpartum moms to make sure that we're looking for the signs and symptoms of depression and anxiety. Um, we know that mothers can experience anxiety for the first time with a pregnancy, but sometimes they can have prior history of anxieties in which they show again during the prenatal period. What I didn't mention are some of the symptoms of depression as well as some of the symptoms of anxiety. When we're thinking about depression, we're looking at depressed moods, sadness most of the day, nearly every day. Oftentimes, depression can show itself in lack of appetite, um, decrease in weight loss, but sometimes it can be fluctuation in weight and appetite. Sometimes women eat more when they're depressed because they're comfort eating. Sometimes women can gain weight. So when you see significant losses or weight gain, that could be a sign of depression. And when you see disturbance in appetite, that can be a change in appetite in that woman, whether it's increasing or decreasing, that could be signs of depression. Feelings of guilt, depression, irritability are also symptoms of depression. Um, Sometimes women who are experiencing depression may not be able to find the language to or the courage to admit that they're having these symptoms, and oftentimes they're afraid to express that they're having these symptoms as well. Sometimes guilt also finds its way into feelings of guilt and hopelessness, also find their way into symptoms of depression. Anxiety symptoms include excessive worry, feeling keyed up or on edge, having racing thoughts, not able to get disturbing thoughts out of your mind. Sometimes they're disturbing thoughts about themselves, wanting to harm themselves, um, sometimes wanting to harm their babies. And and oftentimes pregnant and postpartum women are afraid to share these feelings and thoughts that they're having because they feel as though that they're going to be penalized for having these thoughts. And oftentimes they are penalized for having those thoughts. Sometimes child welfare services are called rather than trying to funnel these women to the supports that they need to address these thoughts and feelings that they're having. Risk factors for anxiety can also include health challenges during your pregnancy, labor and delivery challenges, having traumatic delivery, which, as I talked about earlier, African American women are high at risk for maternal mortality related to delivery and pregnancy. And having a baby with health challenges can also increase your risk of anxiety. And this has strong implications for African American women who we know are high risk for infant mortality and having low birth weight infants who oftentimes can wind up in the newborn intensive care nursery. So, again, screens are key as well for anxiety. We have plenty of screens that we do. We have perinatal anxiety screens for women. We have Edinburgh postnatal depression screen for pregnant women as well. We have other screening tools that we can also use at the postpartum level. We tend to use Edinburgh prenatally as well as postpartum. And these screening tools help us understand how women are scoring and how we support them in terms of outpatient, inpatient, sometimes psychotropic medication, which I'll talk more about later. But these early screens help us understand when mothers are struggling with depression and anxiety. And then it really helps us really hone in and give them the support that they need. We really need to move away from punitive measures for mental health challenges as well as substance use challenges. What we find is that these punitive measures really silences these mothers in terms of not wanting to disclose that they're having these challenges. It really alienates them from the healthcare systems that are meant to support them, not just prenatally and from a postpartum standpoint, but with their mental health and substance use challenges that they may be experiencing. Postpartum psychosis, not as common, but very, very serious. About 1 to 2 out of 1,000 women actually experience postpartum psychosis. But postpartum psychosis can present itself as delusions, hallucinations. These are women hearing voices and seeing things that are not there. Oftentimes, this is considered a medical and mental health emergency. Mothers' safety is at risk when women are experiencing postpartum psychosis, and the infant's health is at risk and safety is at risk. It is a serious condition. And when you think that a mother may be experiencing postpartum psychosis, it is important that you give them to immediate medical treatment as soon as possible. This can be emergency psychiatric facility. This can be an emergency room in a hospital. Again, not as common as your anxiety and depression. They tend to be most common in the population as well as in prenatal and postpartum. But again, should be taken very seriously and understanding when it's presenting in pregnant and postpartum women. PTSD, post-traumatic stress disorder. Different studies cite the different prevalence in pregnant women of PTSD. Some studies show that it's at approximately 21%, but can be up to 40% in high-risk populations. So post-traumatic stress disorder can occur through many ways. Interpersonal violence, intimate partner violence, experiencing traumatic deliveries, natural disasters, or just experiencing life-threatening experiences or witnessing life-threatening experiences of others. Again, this can happen through natural disaster as well. But post-traumatic stress disorder can appear in physiological symptoms. This can be fast heart rate, sweaty palms, nervousness, feeling anxious in certain scenarios. It can be experienced as somatic symptoms such as stomach aches, headaches. Um, some women report heaviness in their chest, pain in their chest, such as they feel like they're having a heart attack. Um, Inability to sleep, nightmares. And it is concerning when women experience PTSD. When they have infants who are low birth weight and may find themselves in and newborn intensive care, we know that PTSD can be triggered on higher levels. So we also want to make sure that we're doing our due diligence as healthcare providers to make sure that we're also screening for PTSD. Oftentimes, women can experience PTSD prior to pregnancy or have experiences that result in PTSD, life altering experience, life threatening experiences prior to that. But depending on that pregnancy course and that labor and delivery, it can reactivate that PTSD. And so we need to make sure that we're doing our due diligence on understanding the histories of our mothers, whether they have histories of violence, histories of trauma, and understand how those histories may impact that pregnancy and that delivery course, especially for our African American women who oftentimes have poor outcomes as it relates to pregnancy, but also mistrust and poor interactions with our healthcare systems. That can serve to re-trigger traumatic experiences and increase the risk of PTSD. And so now that we understand a little bit of what are some of the major challenges that are impacting our pregnant and postpartum women, and now that we have an understanding a little bit of some of the perinatal mood disorders that impact women in pregnancy and in postpartum, I want to connect the dots between those social issues as well as those disorders, and then tie it up by talking about treatment and support. What we do know is that when we're thinking about what our pregnant and postpartum populations are facing, when we think about the racism that African American women endure in society and how that impacts their pregnancy, when we think about the traumatic experiences, when we think about substance use populations and the trauma that substance use bring in the lives of pregnant women, it's not hard to understand how depression and anxiety can find its way into this population. When we talk about imprisoning rather than public health approaches, that reactivates PTSD as well. And so we really need to understand how our responses to maternal mortality, how we respond to the care or the lack of care, inappropriate care that our pregnant and postpartum African American women are receiving. They are at higher risk for having depression and anxiety and PTSD. And we need to make sure that we understand these risk levels, and we need to make sure that we do a better job of supporting our pregnant and postpartum population, but also increasing the supports that we provide to African American women, our Latinx women, all minority populations. How then do we improve treatment and support for this population? One, understanding the signs and symptoms. And we talked about some of the signs and symptoms of depression and anxiety. Once you understand the signs and the symptoms of these disorders, you are better equipped to highlight and identify these challenges in our pregnant and postpartum populations and then support them. And I'm talking not only to our medical professionals, but I'm also talking about families and friends, significant others, these whether it's spouses of pregnant and postpartum women. When you see that they may be expressing concerns, or you're witnessing or observing these symptoms and signs of depression, anxiety, PTSD, or possibly postpartum psychosis, you can then alert the proper mental health professionals to support pregnant and postpartum women. And for my professionals, when you understand the signs and symptoms, you can begin those earlier screens early in the course, whether it's prenatally or postpartum. But we need to make sure that we are not dropping the ball in terms of screening and treatment. You want to enlist the help of professionals early, because what we know is that the earlier we get treatment and support to these mothers, the most likely that their outcomes will be improved. We can also do things like instill hope and understanding. We can also talk about some of the statistics with these pregnant moms and let them know that they are not alone, and that sometimes being pregnant causes those hormonal imbalances that can cause these mood challenges. We can also ask them about their histories to see if they have trauma histories, to see if that how that trauma history may impact their pregnancy. We can do a better job listening to African American women when they're having concerns. Sometimes they'll tell the providers that they're having headaches, they're suffering from headaches, or they're not feeling well, they are nauseous, and we need to listen, do the proper health screenings, and make sure that maybe mothers are not experiencing preeclampsia that can cause them to go into preterm labor. Maybe we need to do a better job with training our providers and doing that, having those critical conversations about biases, racial biases that exist. Sometimes it's not bias, sometimes it's racism. Really doing the assessment of your healthcare facility to know, um, are you serving the needs of all cultures that present, not just language interpreting services, but what are we doing to really understand the different cultures that present? And are we doing a good enough job to understand from their perspective how they're feeling, how they're doing? And are we not using racialized eyes, but supportive, nurturing environments to support pregnant and postpartum women? Are we tending to spiritual needs? Are we supporting spiritual needs of all cultures? How are we enlisting family support? Are we inquiring about family support? We can only do but so much as providers, but we can screen, we can treat, but we also need to know what's going on when pregnant and parenting women are not receiving treatment in front of us in doctors' offices. How are their home environments? And are we supporting their needs in those home environments? Whether these are housing challenges, whether it's intimate, we're doing screenings for intimate partner violence, whether we're understanding the communities in which they're living, we're understanding that they have the support that they need and that they're safe. And then we can then do our job of treating the mental health challenges through medication and or psychosocial treatment. Some some patients respond well with medication. Some patients need a combination of medication and psychosocial treatment. What we know is that patient outcomes are enhanced when it's a combination of medication and psychosocial treatment. But this can be tricky with pregnant women because pregnant women may not be able to take all psychotropic medication because it has implications to the unborn child. And so, again, we need a team of providers, your OBGYNs, psychiatrists, your nurses, midwives, primary care team. We all, pharmacists, we need to all be on the same page to make sure that the treatment we're using standard of care, and we're making sure that the treatment, which can be complicated for pregnant and parenting women, particularly understanding what that birth plan is, because oftentimes mothers may choose to breastfeed as well, and whether their prescribed medication may also have implication to their ability to breastfeed. So again, we need to make sure that we enlist the help of professionals, build a team of professionals around our pregnant and postpartum women so that we can address their unique needs in pregnancy and in the postpartum period. We have a vast amount of treatment approaches at our disposal to support pregnant and parenting women, and I want to take the time now to talk about some of these treatment approaches. Cognitive behavioral therapy is an evidence-based treatment approach where we're looking at the thoughts and feelings of patients and understanding how those thoughts and feelings impact their behavior. And when we're thinking about mood disorders, particularly depression and anxiety, we really want to understand what are some of the thought processes that are going on, and the thought patterns that pregnant women are having. Do they feel guilty? Do they feel not good enough? Do they have concerns about their pregnancy? Do they have concerns about the delivery? Rightfully so, based on the evidence and what we know. But really understanding what those thoughts are and trying to improve those thoughts. We know that if we can help them think about things differently, that it does impact how they feel, their emotions, their mood, and then they can then impact their behavior. We can empower them from a behavioral standpoint to take their health care in their own hands. We can advocate for them and teach them how to advocate for themselves as well. Making sure that we understand spiritual supports, particularly for communities of colors, and build those spiritual supports around our pregnant and postpartum women as well. We also have substance use screening tools such as ESPERT, screening, brief intervention and referral and treatment. And we also have motivational interviewing. And these practices are meant to improve outcomes by motivating mothers to have healthier lifestyles, make healthier decisions about themselves and as it relates to substance use. Really doing psychoeducation as well in terms of what substance use may mean in terms of their overall health and the impacts of the fetus. Making sure that we're doing that counseling, not just at the beginning, but throughout the pregnancy and postpartum as well. We also know that mother baby programs are also crucial in supporting mothers. We're th- when we're talking about mother baby programs, I'm talking more broadly, but I'm going to talk more in detail about what some of the types of mother baby programs are out. We know that visiting nurses programs that provide home visiting support are known to improve outcomes for pregnant and postpartum women, not just mental health outcomes, but their health outcomes as well. Having providers check in on mothers weekly to see how they're doing, making sure that they have the supports of the community around them improves outcomes. Making sure that we again approach pregnant and postpartum women as a team with midwives, psychologists, psychiatrists, social workers, clinical social workers in these mother baby programs help. And we know that through these programs, we can again deliver those screenings and refer to treatment, whether again, those are outpatient treatment, inpatient, residential mother baby programs. Sometimes this is group and or peer support as well. What we also know is that there are not enough mother baby programs, particularly when we talk about substance use, um, pregnant women who are also our substance use population. Mother baby programs oftentimes are residential or inpatient programs that support the substance use needs of pregnant women and postpartum women. It helps them maintain sobriety, get the peer support that they need, as well as the professional support that they need throughout the entire pregnancy, which will decrease the likelihood of that woman experiencing an infant with neonatal abstinence syndrome. However, that's not always possible, particularly if it's a woman who is experiencing opioids. Oftentimes, those women need medication assisted treatment, whether that's methadone programs, Suboxone programs, and they need these programs in order to not go back to the streets and use heroin and other types of even deadlier substances. But even though they're on medical assistant treatment, it is what is needed to keep them um, managed in terms of their withdrawal symptoms. And they need to be on these medications. Oftentimes, there's a lot of stigma for pregnant women for being on these programs, but we know these programs help and support them. So we need to remove the stigma and more support them and tell them that they are courageous for understanding that they have a substance use challenges and be commended for taking the steps for medical assisted treatment programs that we know will improve overall their health, which improves the outcome for the infant. But we do know there's a consequence to that, and that may also be neonatal abstinence syndrome. Women who are on methadone and Suboxone programs also have infants who are suffering from neonatal abstinence syndrome. But the more that we prepare them for that and educate them and let them know that they're doing the right thing despite of, improves outcome and that mother's ability to deal with the mental challenges and the trauma of having to deal with an infant that most likely or has a high risk of being in the newborn intensive care unit due to um, neonatal abstinence syndrome related to treatment. And so we do need to understand that sometimes the mothers don't understand why their infants are in the NICU when they did the right thing by getting help. But again, we need to do better as providers by educating them that they are doing the right thing, and they will then expect that outcome. And it doesn't always happen, but it can happen. At least they're better prepared. And again, that is a critical and a unique period where we need to support the mothers and reinforce that they've done the right thing in terms of their substance use. But entering into a mother baby program helps reinforce these things. Also, mother baby programs encourage things such as breastfeeding, um, which we know keeps women substance free and we know improves mental health outcomes as well. There are many studies that show the benefits of breastfeeding in terms of improving depression and anxiety, but also giving mothers motivation to stay clean from substances. So, oftentimes in these mother baby programs, whether it's home visiting programs or in um, residential programs, they're going to continue to promote and encourage mothers to make decisions that support them, their mental health and substance use, but also the baby too. And I also now want to take some time to talk about some of the things that we're doing at Howard University to support the mental health of all people. But it also has implication to maternal mental health as well. One of the things that we're doing is we're doing a lot of suicide education through QPR. We have the Howard University Mental Health Awareness Grant and suicide prevention. And through this grant, what we're doing is we're trying to do more trainings in the community, locally, regionally, and nationally, in terms of suicide prevention. And we believe that building the capacity of communities, families, organization, healthcare um, settings, that we can do a better job of screening for mental health as well as suicide. And this then improves the outcomes of all populations, particularly pregnant and parenting women. And we do that through QPR, question, persuade, and respond. We also are delivering a series of trainings called Mental Health First Aid. Mental health first aid trainings are similar to QPR in that these are evidence-based training trainings that improve the capacity of individuals, families, organizations to understand the signs and symptoms of mental health challenges, but also empowers individuals and communities and organizations on responding to mental health challenges and giving them the tools that they need to detect these challenges such as depression, anxiety, PTSD, postpartum psychosis, noticing these challenges early, having those difficult conversations, screening and assessment, and referring to providers to do thorough and more evidence-based screening and assessments for these conditions. We pride ourselves in our ability to be able to deliver these trainings, not just to professionals, but to regular people as well, or non-professionals, because we know that oftentimes people don't find themselves in front of professionals because of stigma. So that if we can encourage and support and educate and train families as well, and the communities in which people are living every day, we know that it increases the chances that interventions can occur, as well as the supports put in place to support all populations, including our pregnant and postpartum women. And so this is one of the initiatives that we're focusing on. And of course, opportunities like this with blackdoctors.org. We are also trying at Howard University School of Social Workers, trying to reach out into our communities and strengthen our partnerships so that we can continue to deliver educational webinars such as this, trainings. Again, this is awareness. By improving awareness, we know that we're going a long way into building the capacity of others. And we want to utilize ourselves as resources to the community to support the community in any way that we can. And so I want to take the time now to do a brief recap of what I talked about today and really stress some of the take home points that I want you to leave away from this training today. One, understand that there are some huge, major public health issues that are impacting our pregnant and postpartum women. They are maternal mortality, substance use, particularly the opioid pandemic. There are racism and an assault on our African American women as it relates to perinatal health outcomes and health disparities and disparities in outcome as it relates to their birthing experiences and their delivery experiences. We know that pregnant and parenting women are dealing with um, concerns related to their infants, infant mortality, low birth weight, and neonatal abstinence syndrome as well. And these things play a role in mental health. This increases the risk factors for depression, anxiety, PTSD, and one of the most concerning, postpartum psychosis. You learned today some of the symptoms associated with depression and anxiety, and I'm hoping you understanding these symptoms help you better understand the signs and symptoms and you're able to act early in the lives of pregnant and postpartum women. And also make sure that you understand who to refer them to. Mother baby programs, social workers in your community, outpatient, inpatient, group peer support, referrals to medical providers, OBGYN. Oftentimes, these pregnant and parenting women are most often with their family and significant others, so you play a crucial role in detecting and helping funnel these women to the support and the professionals that they need to improve. Please know that when we talk about mental health and substance use with pregnant and postpartum populations, it's complicated, and treatment is also complicated because of the pregnancy. Also, we know that the biological connection to that baby and the changes that happen biologically puts them at risk for these mood disorders as well, further complicating the situation. But what we need to do is again normalize that this does happen in a large percentage of the pregnant population, and normalize these experiences that women are having. It does happen, right? But it's not normal in terms of the need to get help. It is common to have depression in pregnancy. It's common to have anxiety, but it's not common to sit there and feel that way without getting the help that you need. And there is help out there, and we need to instill that hope and make sure we connect them to care. Know that there are evidence based models out there that can support, but we can't do these treatments without proper screening for depression and anxiety and substance use. With that screening, constantly and routinely, we can get pregnant mothers the help and the support that they need. And so I'm getting close to my time here. And so I hope this webinar, this, increase your awareness, give you some things to think about. I hope when you encounter pregnant and postpartum women that, you know, through your experience with this training today, that you understand a little bit more when you see a mother who may be depressed, sad, crying. You notice that, hey, that might be a sign of depression, and maybe I need to ask some more questions and recommend that she get support. If you encounter a pregnant woman who seems worried about leaving her baby, worried about her significant other watching the baby, scared to go to the grocery store, nervous about the pregnancy, nervous about the medical providers. We know that there are reasons for that because there are challenges to pregnant women, but we also know that those are that symptoms of anxiety, being keyed up and on edge. We know that if a woman is dealing with post traumatic stress disorder, if they explain to us a history of trauma, a history of experiencing life violence, threats to her life, or witnessing the threats to life of others. Think about PTSD and getting that mother screened for that as well. And again, if a mother discloses to you, or a postpartum woman discloses to you that she's hearing voices, she's seeing things that are not there, delusions, hallucinations, erratic, odd behavior, thoughts about hurting herself, thoughts about hurting her child, I want that to raise a huge red flag and a radar about the risk of possible postpartum psychosis. Recognize that immediately as a medical emergency and divert that mother to emergency medical care as soon as possible. And so that is my time with you all. I hope that you take a lot from this presentation and think about ways that we can support our pregnant and postpartum women and really be that source of support for them in the future. Thank you so much for your time.